Welcome to this explainer, nursing students. If you've ever felt completely overwhelmed by the sheer volume of milestones, reflexes, and developmental stages you're supposed to just somehow know for pediatric nursing, I want you to take a deep breath. Today, we're going on a really calm, structured journey through pediatric development. We aren't going to sit here and just memorize lists of facts. Instead, we're going to consciously build a conceptual framework for stage-appropriate care. It's a framework that will guide you not just on the clinical floor, but straight through your exams. Okay, let's dive into this.
Here is the absolute most important thing to remember. A child is not a tiny adult. This is literally the central truth of all pediatric nursing. You can't just take your adult nursing principles and shrink them down. Our clinical assessments, our communication styles, our safety measures, and even how we conceptualize pain, it all has to completely adapt to the child's specific developmental stage.
To get there, we'll be following a really clear chronological roadmap today. We'll start with newborns and infants, move right into the toddler stage, then the preschool years, school-age development, and finally, we'll wrap up with the adolescent transition.
Let's jump right into our very first stage, newborns and infants, which covers that incredibly rapid period of growth from birth all the way up to their first birthday.
Think about it this way. If a tiny infant could actually speak to you, their core psychological drive would simply be, trust me. This fits perfectly with Erikson's stage of trust versus mistrust. During the newborn phase, which is birth to 1 month, and into the infant phase up to 1 year, they are rapidly transitioning to life outside the womb. Their entire world is built on consistent caregiving, feeding, warmth, touch, being comforted. That is what actually builds the foundation of trust. If you disrupt their attachment, you're literally disrupting their psychological foundation.
Cognitively, infants are in Piaget's sensory-motor stage. They're learning everything about the world through movement and their senses. A massive cognitive milestone here is object permanence. As an infant gets closer to the end of their first year, they finally start to realize that just because mom or dad leaves the room, they haven't ceased to exist. Until that concept develops, separation is intensely stressful for them. And honestly, even after it develops, separation anxiety plays a major role in how they experience something like a hospitalization.
So bringing this into actual clinical practice, your nursing priorities are pretty clear-cut. Number 1, you absolutely must promote attachment. When an infant is in the hospital, maintaining caregiver contact is your biggest move. For assessments, remember, they can't exactly point to a smiley face pain scale for you, right? So we rely on behavioral indicators, like the FLAX scale, where we're looking at facial expression, crying, and consolability. Nutrition is all about breast milk or iron-fortified formula, and we definitely can't overlook safety. Safe sleep means back to sleep on a firm, flat surface with 0 loose objects. And once they start rolling, which is always when you least expect it, strict injury prevention becomes a huge deal.
And that increasing mobility we just mentioned, that leads us straight into our next section, the highly active toddler stage, spanning ages 1 to 3.
While the infant wanted trust, the toddler, well, they demand control. Their core drive is, let me do it. This is Erikson's autonomy versus shame and doubt. This is the era of parallel play, pushing and pulling toys, and their absolute favorite word in the English language, no. They are desperately seeking independence. So any loss of that control, like being confined to a hospital crib, is a massive stressor that usually results in protest, despair, and eventually detachment. Because they have this intense fear of separation and losing control, you have to completely flip your assessment approach. First things first, just let them stay right there in their caregiver's lap while you observe from a distance. Give them a minute. Then you can let them safely touch your stethoscope or maybe look at your pen light just to build a little bit of rapport. And a pro tip, always save looking in their ears or their mouth for the absolute end, because once they start crying, your easy assessment is officially over. This intense need for control sets up what we call the classic toddler trap. This is a huge NCLEX trigger, by the way. If you ask a toddler who has very concrete, egocentric thinking, hey, do you want to take your medicine? They are going to look right at you and say, no. And honestly, they'd be right to, because you gave them the option. Instead, you want to offer 2 acceptable choices. Ask something like, do you want your medicine in the red cup or the blue cup? See what happens there? You maintain the clinical control, but the toddler still gets to exercise their autonomy. Now, with all that autonomy comes some serious physical risks. Toddlers are walking, they're progressing to running and climbing, but let's be honest, they have absolutely 0 judgment. So injury prevention is a massive priority.
We're talking constant water supervision because of the drowning risk, meticulously locking up all medications and chemicals to prevent poisoning, and proactively preventing falls, burns, and choking. Also, they need to remain in rear-facing car seats based on current safety guidelines.
As physical coordination and language really start taking off, we naturally transition into the preschool years, which is ages 3 to 6.
Here, the motto shifts completely. Now it's, let me imagine it. Under Erickson's framework, this is initiative versus guilt. They want to explore, they want to create, they want to initiate activities. We start to see associative play emerging here. They're actually playing together, doing dress-up, and constantly imitating the adults around them.
Cognitively, they've entered Piaget's pre-operational stage. Their imagination is absolutely incredible right now, but it leads to a really interesting phenomenon called magical thinking. They literally believe that their own thoughts or wishes can directly influence the external world. Because of this, they tend to interpret language very literally. If you tell a preschooler you're going to take their blood pressure, they might actually think you are taking something out of their body and you aren't going to give it back.
And that magical thinking brings us to the classic preschool trap. A hospitalized preschooler might genuinely believe, I was mean to my little sister yesterday and that's why I'm sick today. They create these incorrect, self-blaming explanations for why they're in the hospital. Your absolute biggest nursing move here is to correct those misconceptions. Never, ever assume a preschooler understands cause and effect. You need to provide simple, literal explanations assuring them that medical procedures and illnesses are absolutely not a punishment.
Moving right along, we enter school-age development. This covers ages 6 to 12, where logical thinking and peer friendships really start to rule their world.
The internal drive evolves once again. Now it's, let me accomplish it. This is Erickson's industry versus inferiority. For a school-age child, their whole sense of self is built on success. That means success in school, learning new hobbies, playing team sports, and participating in cooperative play. For them, competence is their currency.
Since they're now in Piaget's concrete operational stage, they actually grasp cause and effect. So, if they're hospitalized, their biggest stressors aren't monsters under the bed. They're missing school, being separated from their friends, and losing that feeling of competence. So what's your nursing action? Explain what's going to happen and exactly why. Let them ask questions, strongly encourage them to participate in their own care. And when it comes to pain assessment, you can finally start relying on their self-report using numeric or FACES scales, depending on their specific ability.
Finally, we arrive at our last major developmental stage, the adolescent transition, bridging ages 12 to 20.
This phase is marked by puberty, massive physical growth spurts, and major cognitive shifts. The adolescent is basically screaming, "Let me become myself." Welcome to Erickson's identity versus role confusion. They're actively trying to figure out their values and their place in the social hierarchy. Peer influence is profoundly powerful right now, and body image becomes exceptionally important to them. Adolescents are using formal, operational thinking now. They can reason abstractly and they can plan ahead. So what's their biggest stressor in a medical setting? Loss of privacy and losing their independence. The ultimate NCLEX trigger to remember here is that you must treat the adolescent as the primary participant in their care. You need to talk directly to them, not just over their heads to their parents. Offer them confidential interview time when you can, and crucially, this is the time you really need to thoroughly screen for psychosocial risks, things like depression, anxiety, substance use, and general safety risks.
Okay, let's pull all of this together. What is the absolute master key to unlocking those really tough pediatric questions on your exams? It's actually pretty simple. Match your nursing intervention directly to the child's psychological drive. If you truly understand what is motivating that child at their specific developmental stage, you can seamlessly deduce the correct clinical intervention, and you won't have to memorize endless textbook lists to do it.
Think of this summary as your ultimate cheat sheet. Let's trace it one more time. For the infant, the focus is trust. Your big move is maintaining caregiver contact. Moving up to the toddler, it's autonomy, so you offer them limited choices. Next, for the preschooler, it's initiative and imagination. You provide simple, literal explanations to fight that magical thinking. For the school-aged child, it's industry and competence. You explain things clearly and involve them. And finally, culminating with the adolescent, it's identity. You fiercely protect their privacy and autonomy.
By understanding this natural progression, you aren't just regurgitating facts, you're learning how to genuinely see and properly care for your pediatric patients. You have the framework now, so I'll leave you with this thought. Now that you definitively know they aren't just tiny adults, how will you consciously adapt your care, your communication, and your entire approach for the very next child you treat?
Keep this framework in your back pocket, trust your clinical judgment, and you are going to do fantastic out there. Thanks for joining me for this explainer.